Good afternoon, fellow academicians. I am truly humbled by this opportunity to share our experiences in La Consolacion University, Philippines, and the Philippine Society of Anatomists Incorporated in incorporating primary healthcare into the basic medical education curriculum. I will be speaking in my capacity as the Dean of the First College of Medicine in the province of Bulacan, granted full government recognition, and with LCUP being a Catholic university. Before being dean, I was a trained administrator, middle manager, and faculty of a well-established PAASCO Level 4 accredited medical school. I will also be speaking as the current president of the Philippine Society of Anatomists Incorporated, working towards a unified curriculum incorporating primary healthcare, and as part of a team helping a state university. My task is to demonstrate steps in arriving at a basic science syllabi incorporating primary healthcare. But at the end of my presentation and this workshop webinar, you, the participants, will be able to create a syllabus incorporating primary healthcare in basic medical science courses. The Philippine medical education is patterned after the US medical education. That is the reason why a transition was seen from a competency-based curriculum to an outcome-based education strategy. Along with the full mandate on the OBE approach is the issuance of CHED Memorandum Order 18, Series of 2016, where the 10 program outcomes of the Doctor of Medicine program were identified. Sample syllabi were part of the appendices of the said CMO. Last June 30, 2021, a Joint Administrative Order 2021-0001 was issued by DOH, CHED, and PRC on the guidelines for the reorientation of the health professions education curricula and training programs to primary healthcare. Our challenge is to produce a licensed MD, a licensed doctor, who is a primary healthcare provider equipped with the 10 program outcomes, which means that they are not just trained in managing patients in the hospital, but also in the community where there may be lack of resources. How then do we do this while we fulfill the following: CMO 18, Series of 2016, the Joint Administrative Order 2021-0001, our existing curricular strategy or curriculum of an outcome-based education approach, and the type of questions and examination in the physician licensure exam. Before we can actually incorporate primary healthcare into any basic medical science course, we have to be clear on the role of basic sciences in the medical curriculum. In 2010, the Flexnerian advocacy was practiced by almost all medical schools all over the world, following a foundational preclinical phase aimed primarily at providing medical students with a scientific basis or the so-called foundational knowledge of medical education, followed by a clinical phase of education in academically oriented hospitals. However, concerns on this type of curriculum was seen in the 20th century, wherein students were unable to apply basic science knowledge, concepts, and principles acquired in the preclinical years to medical problems encountered in the clinics. To address these concerns, as seen on the report of Drs. Matthew Gui and Dujipa Samarasekera from the National University of Singapore Medical Education Unit in the 21st century, interactive teaching learning strategies are needed to address the two major shortcomings of the Flexnerian curriculum, which are poor student recall of the basic science knowledge on the clinical years and the lack of ability of students to apply knowledge of the basic sciences to medical problems encountered in the clinics. The outcome based education strategy is another way to address gaps identified between the preclinical and the clinical phases. In the United Kingdom, as practiced by the University of Dundee, a spiral curriculum was advocated wherein foundational knowledge is given in year one, but application of these foundational knowledge is reinforced and reiterated in all year levels. For the US Mayo Medical School, a block-based instead of a course-based type of curriculum, vertically and horizontally, was implemented. All these strategies were done to ensure and promote integration and not compartmentalization. These are the 10 program outcomes of the Doctor of Medicine program seen in CMO 18 series of 2016. Are these program outcomes aligned towards the graduates being primary healthcare provider? Were the core syllabi done and implemented by medical schools aligned towards achieving these outcomes? Those were our questions in LCUP College of Medicine when we had our planned curriculum evaluated after it was initially implemented in academic year 2017-2018. In academic year 2018-2019, we were certain on the kind of graduates that we envisioned for LCUP College of Medicine, the so-called TATAC LCUPCOM. We envisioned them as physicians who are clinically competent, empathetic, holistically trained to manage patients, both in the hospital and community setting, rendering humble and generous service. The Augustinian Sisters of Our Lady of Consolation, headed by then Superior General Sister Niseta Vargas, summarized it in a phrase as doctors with compassionate hearts. As a new College of Medicine in an established ISO certified Catholic university, we initiated the following steps in following CMO 18 series of 2016 and eventually the JAW. We added an 11 program outcome following the kind of graduates that we envisioned. We wanted Augustinian teachings and core values practiced, if not exemplified, not just by our students or graduates, but by our faculty as well. We also reviewed and checked on the importance of these core values in the practice of medicine, like the crown of all Augustinian values, which is humility. Humility comes with service, and much of the practice of medicine is generous service. Being the first College of Medicine in the province of Bulacan, and the lack of doctors serving the remote areas of the province like Sitio Pamarawan, we had to gather and consider local and national statistics on the top 10 causes of morbidity and mortality, both in the community and hospital, especially with our referral facility of all the districts of Bulacan, the Bulacan Medical Center. This is also our base hospital. This is where the incidence and organophosphate poisoning being one of the top 10 causes of morbidity and mortality in the emergency room and in the community was actually seen. That is the reason why we incorporated discussions on organophosphate poisoning even in the basic sciences like biochemistry, in preventive medicine, on that part of disease prevention and control, on the risk factors and prevention of organophosphate poisoning, medications and substances to treat organophosphate poisoning in pharmacology. And of course, clinical case discussions incorporating both knowledge in the basic and clinical sciences on the detection and the symptoms, signs and symptoms of patients with organophosphate poisoning. We all know that a good curriculum is dynamic and that which addresses the needs of the learners. So in academic year 2020-2021, after reviewing our delivery of instruction and curriculum implementation for the previous academic year, we had to ensure that we focus on core knowledge and skills and once again reinforce on the importance of a complete and thoroughly done history taking and physical examination. Like most medical schools, topics were based on textbooks or prescribed textbooks and references, and not exactly relating them to local, national, and global epidemiologic statistics. Even prior to the implementation of the Joint Administrative Order, we have placed prime importance on community medicine rotation of the clinical clerks. This rotation is given the same importance and attention as the four major rotations of internal medicine, pediatrics, obstetrics and gynecology, and surgery. Clinical clerks were also trained to manage patients in all settings, to include that of communities with low or lack of resources like laboratory facilities. There is still a lot of work to be done, and we are yet to fully reorient our teaching learning activities and assessment towards graduates being primary healthcare provider, like having integrated case discussions involving all disciplines per year level and more applied and performance-based assessment, the so-called authentic assessment. With my other hat as the current president of the Philippine Society of Anatomists Incorporated and a one-year term for every executive council of the society, we are to listen and collaborate on how the schools reoriented their human anatomy teaching learning activities during our mid-year convention. We are also hoping to the Association of Philippine Medical Colleges Incorporated to propose a unified human anatomy curriculum following the Joint Administrative Order 2021-0001. In the past 10 years, highest failure rates in the physician licensure exam were noted in human anatomy and that of surgery. That is the reason why we would like to review the table of specifications and the type of questions given in human anatomy for the past years and see how we can collaborate and help medical schools in teaching and learning human anatomy in order to increase the passing rate of graduates in the physician licensure examination. Everything that I discussed are small and humble steps towards developing basic science courses syllabi towards primary healthcare. Allow me to give my humble suggestions in ensuring that we produce physicians who are primary healthcare providers. To facilitate implementation of any syllabi done, collaborative work and strong coordination must be ensured between SHED, PMA, PRC, and the Association of Philippine Medical Colleges Incorporated. All assessments given in the undergraduates must simulate that of the physician licensure examination. And if the approach in the PLE is still course-based, recall, questions, and not applied, then implementation will not be consistent and congruent towards primary healthcare. As a new medical school working towards a success framework, of other well established medical schools, it is our fervent hope and prayer that our graduates will be successful, compassionate primary healthcare providers. These are the references that I used for my discussion. A primary healthcare provider is not just a good physician who treats the disease, but a great physician who treats the patient who has the disease. Thank you for listening and have a good afternoon.